Pharmacology SAQ 16 Drug Interactions. A. Briefly describe the pharmacodynamic interactions between two drugs when administered together. 3 marks. Pharmacodynamic interactions include summation, potentiation, synergism, and antagonism. Summation is the action of two drugs are additive, but each has an independent action of its own. MACs of inhalational anesthetics are additive. Ramipil and beta blockers act additively to lower blood pressure by an indirect interaction, one via the renin-angiotensin system and the other via adrenoceptors. Potentiation. The action of one drug is amplified by the addition of another, which has no independent action of its own. Probenecid reduces the renal excretion of penicillin, such that the effect of a dose of penicillin is enhanced without itself having antibiotic activity. Neuromuscular blockade of non-depolarizing muscle relaxants are potentiated by gentamicin. Synergism. The combined action of two drugs is greater than that would be expected from a purely additive effect. Propofol and remifentanil act synergistically when used to maintain anesthesia. Midazolam and propofol's anesthetic effects are synergistic. Various analgesic combinations such as NSAIDs and opioids and alpha-2 agonists, opioids and local anesthetics, opioids and NMDA antagonists frequently demonstrate synergistic effects. Murinone and adrenaline are positive inotropic agents with different mechanism of actions that interact synergistically to improve myocardial contractility. Antagonism is an interaction between two or more drugs that have opposite effects on the body. Flumazanil antagonizes benzodiazepines, and naloxone antagonizes opioid effects. Alpha-1 adrenergic blockers antagonizes alpha-adrenergic agonists. Ethanol antagonizes the toxic effect of methanol by displacing it from the enzyme that oxidizes methanol. These drug interactions may be demonstrated by plotting an isobologram. B. Explain the drug interactions affecting neuromuscular blocking agents. 7 marks. By location of action. Drugs that potentiate non-depolarizing muscle relaxants. Presynaptic drugs includes volatile anesthetics, which reduces alpha motor neuron activity, peripheral nerve local anesthetics, and tetrodotoxin, which reduces axonal action potential, hemicolinium by reducing choline uptake, Vesamicol by reducing acetylcholine transport into vesicles, furosemide by reducing AMP and ATP synthesis, volatile anesthetics by blocking presynaptic nicotinic acetylcholine receptors, calcium channel blockers, magnesium, aminoglycosides, and volatile agents by blocking L-type calcium channels, Botox which cleave SNAR protein and reduces acetylcholine release. Postsynaptic drugs includes those that block postsynaptic nicotinic acetylcholine receptors, such as non-depolarizing muscle relaxants, volatile anesthetics, aminoglycoside, and quinidine. Desensitization blockade caused by volatile anesthetics and barbiturates. Local anesthetics, which reduces sodium flux and inhibit perijunctional action potentials. Postjunctional drugs includes dantrolene, which inhibits skeletal muscle ryanodine receptor. By drug type. Drugs that interact with suxametonium. Drugs that potentiate suxametonium's effects. Suxametonium's actions can be prolonged by anticholine esterases, such as neostigmine and organophosphates, that inhibit plasma choline esterases, and by drugs that compete with suxametonium to be metabolized by esterases, such as etomidate, propanidate, ester local anesthetics, methotrexate, monoamine oxidase inhibitors, esmolol, and diamorphine. Other inhibitors of plasma choline esterase includes metoclopramide, hexafluorinium, cyclophosphamide, trimetaphan, and etomidate, which can potentiate suxametonium's actions. Phase 2 block caused by repeated doses of suxametonium is potentiated by inhalational anesthetics. Azathioprine increases acetylcholine release by inhibiting phosphodiesterase, increasing CAMP, and this potentiates suxametonium's effects. Drugs that antagonize succinylcholine effects include anticholinergics such as atropine and glycopyrronium, which antagonizes the bradycardia caused by succinylcholine stimulation of muscarinic receptors in the sinoatrial node. Drugs that may reduce succinylcholine-induced myalgia include non-depolarizing muscle relaxants, lidocaine, diazepam, dantrolene, calcium, magnesium, and chlorpromazine. Hypokalemia induced by diuretics antagonizes succinylcholine effects. Drugs that interact with non-depolarizing muscle relaxants. Drugs that potentiate non-depolarizing muscle relaxants include IV anesthetics, benzodiazepines, succinylcholine, inhalational anesthetics, opioids, local anesthetics, antibiotics, vasopressors or positive inotropes, beta blockers, calcium channel blockers, magnesium, furosemide, long-term steroids, multiple non-depolarizing muscle relaxants, short-term phenytoin, lithium, procainamide, quinidine, and others such as hemicoline, besamicol, Botox, tetrodotoxin, and dantrolene. General mechanisms by which drugs potentiate non-depolarizing muscle relaxants are via stabilization of the postsynaptic membrane, presynaptic inhibition of acetylcholine release, combination of pre- and postsynaptic effects, and other specific effects, which are listed. Drugs that antagonizes the effects of non-depolarizing muscle relaxants includes anticholineesterases, sugammadex, chronic intake of phenytoin, carbamazepine, and corticosteroids, furosemide, short-term steroids, azathioprine, potassium, tetanus toxin, long-term antiepileptics, theophylline, beta blockers, and calcium chloride, with their mechanisms listed here. Drug interactions between individual neuromuscular blockers. The clinically significant interaction between non-depolarizers and depolarizers may be due to blockade of the presynaptic nicotinic receptors by depolarizing muscle relaxants, leading to decreased acetylcholine mobilization and release. When non-depolarizing muscle relaxants are administered after succinylcholine, their effects are prolonged. Giving succinylcholine after a depolarizing muscle relaxant prolongs the onset of succinylcholine. Additionally, hypothermia doubles the duration of muscle relaxants due to reduced metabolism and reduced excretion. Hypokalemia increases the transmembrane potential and hyperpolarizes cell membranes, causing resistance to succinylcholine and increased sensitivity to non-depolarizing muscle relaxants. Hyperkalemia has the opposite effect. Hypercalcemia triggers the release of acetylcholine and enhances excitation-contraction coupling. Hence, hypercalcemia reduces the sensitivity to non-depolarizing muscle relaxants. Major burns increases the resistance to non-depolarizing muscle relaxants starting day 10 post-burns, peaking at day 40, and start to decrease at day 60. This is due to altered affinity of nicotinic acetylcholine receptors to non-depolarizing muscle relaxants. However, the exact mechanism is unknown.